And then the final. Wait for it. Potty time. All right. Well, welcome everyone. I'm really happy to be here. The leadoff man, so to speak, on the tee, 8 a.m. That's about my usual tee time. And I played that tune for a particular reason. And the reason is basically I grew up with Johnny Gage, and I know I'm looking around, and I know there's other faces here that grew up with Johnny Gage as well. I'm sure they have. So put your hand up if you know Johnny Gage. Right. So there were special people. You had Johnny, you had Roy, you had Dr. Early, the Dixie Chick, who all us guys really enjoyed on the show, right? And emergency really was the start for me in medicine. It's what got me involved in medicine. You hear that story, it's sort of repeated over and over again. But for me, truthfully, I was a musician. I played the saxophone, and I said, I want to go and become a music teacher. And then my dad became a paramedic in Illinois, and was one of the first paramedics. It was around the time that Emergency came out, and we watched the show every Saturday night, and I was taken away. And so here I am. Good or bad, here I am. But there's also some message there with Johnny Gage and Emergency back in those days. And I want to just kind of draw a parallel to that with you guys. And I apologize for a repeat play. There we go. Use the microphone. Can't hear me? I'll stay here to use the microphone. All right, sorry. I like to walk around a little bit, but so there's been a significant change since Johnny Gage's day. If you had a stroke when Johnny Gage was a paramedic, there wasn't much they could do for you. He could do a lot if you had cardiac arrest, and everyone knew for hypoglycemia he had the flip just right with the D50, right? But with stroke, there's really not been much. There was not much they could do in those days. And that was around the time that this lady here, that's my grandmother. I was in medical school. I used to visit Grandma every Saturday, and I went to see my grandmother one particular Saturday, and she was in her chair. She was awake. She couldn't talk to me. It was an easy diagnosis. I would say her NIH stroke scale was probably around 12 or 14 at the time. She had a massive stroke. She lived in that house alone for years, and she did not want me to call an ambulance. And I couldn't believe it, but I helped my grandmother out of the house. I put her in my car, and I drove her to the South Suburban Hospital in Hazel Crest, Illinois. I was somewhat embarrassed when I arrived because we came by private car, and she obviously had had a massive stroke. And Grandma lived for a year or so after that, and then she passed away. Their care really for the stroke was minimal, if any. And now it's a lot different. There's a stroke care evolution, really. And it's gone from grandmother had a stroke, and she's going to get a feeding tube and be discharged to a nursing home, which in essence is what they did for my grandmother. And now, grandmother had a stroke, and she got a clot-busting drug. And then they removed the clot from her brain in a biplane room. She's doing much better. So we have a significant shift in the care for stroke patients. And we all know that. That's why we're here. There's been a significant evolution. In the 1980s, we started increasing the use of aspirin, or increasing the use of CT, MRI, and carotid ultrasound. And morbidity, mortality came down just a little bit. Aspirin, Coumadin, and heparin were also in use then. Okay. And it wasn't until the 1990s any real change happened when we started to see the use of TPA. First, as you know, it was used in cardiac conditions, but felt like there may be some help for patients that had strokes, so they began to use TPA in the 1990s. And it gathered sort of slow traction, right? It was everyone was skeptical of the drug. There were patients that would bleed. And we fine-tuned through all the tons of different studies. They fine-tuned the way we give TPA to how we give TPA now, which is a much more safe and a reliable way to give TPA to try and help patients recover from stroke. And then what happened in 2014 was the Mr. Clean study, which is Dr. Abuawad's, basically his holy grail. Where are you, Doc? You back there somewhere? Anyone aware of that study, the Mr. Clean study? So that's the study that came out and said, look, we can go like we do for heart attack. We can go after those clots and remove those clots. And there was, in fact, a sustained benefit of endovascular therapy and mortality benefit as well, and it was sustained. At 2 years, they noted 28% for patients that didn't have endovascular treatment versus 33%, 28% survival of patients that did have embolectomy versus 33% that did not. So almost a 5% difference in survivability, which is quite significant. And I would say that Grandma, if she had that option, would have lived a few more years. She would have seen me graduate from medical school. She would have seen my kids born. She would have seen the sunsets. And for me and for all of us, I know that that's what it's about for us. We want the best we can give and deliver to our patients. And we want to try and give them every service possibility so they can see another sunset in Naples and go to their child's graduation. So when we look, and this is strictly EMS, this topic, so there are some EMS guys in the back here on the side. EMS really starts the ball rolling. And without them being properly trained to recognize and improving the outcome in stroke is going to be difficult. So we have to consider them equal partners in the continuum. We have to engage them, and we have to sort of help guide them through what are the best things that they can do to help improve the outcome. Currently, we struggle with when was the last time the patient was normal, and determining whether or not when was the last time they were able to function in a normal way. Right now, the best way to determine this is to say, when were you last seen normal? Instead of when did the symptoms start? And we struggle with that one. We're always trying to figure out when did the chest pain start? When did your right lower quadrant pain start? And instead, we sort of paradigm shift that to when were you last normal? And to do that, we have to recruit witnesses, paramedics, family members, neighbors. And sometimes we can't get that last normal. That last normal window is large. Sometimes it's newspapers have been stacking up for 2 days. So it could be up to 2 days. And sometimes it's the neighbor that saw the patient get up in the morning and walk out to get the newspaper. So what you want to do is try and determine the best you can through competent witnesses when the patient was last seen normal. Most strokes are easy to see, but hidden strokes may be more difficult to diagnose, and the use of stroke scales allows us to diagnose more consistently and identify stroke, particularly in the field. It also assists us with, in EMS with handoff to our paramedics. The stroke scale also allows us to determine if we can triage to an appropriate center. This is vital, and the message has to get across to EMS. Like cardiac, you guys know when you have a STEMI, what do? Aspirin, nitrates, oxygen, etc. But where's the patient going to go? You have 4 or 5 choices locally in the area. So where's the patient going, sir? Say it, please. PCI center, right? So there's either going to go to downtown facility or they're going to go to Physicians Regional, who also can perform PCI. The stroke scale will allow them to help determine who's most appropriate to go to a comprehensive stroke center. And that's the key. That's really the holy grail. Using the stroke scale, you can also increase the time or decrease the time to notification so that the stroke center, the receiving center, can activate their stroke team and get things moving so that they can meet the needs of the patient. This is a little too tricky here, the setup they gave me. So, and then also the last thing is that the stroke scale can help you with the proper handoff of your patient. And this will help you with, will help the staff that you present the patient to be able to appropriately begin and initiate the care that the patient has. And you can give as much detail as possible. In fact, that's the goal. And we'll talk more about stroke scale in just a little bit. Are there other options for transport? This allows the medic in the field to make that decision. For example, let's say they're out in the estates, and many of you know the estates can have a very long ETA to downtown. Are there other options? Should they activate the helicopter? What do we use the helicopter mostly for, guys? Trauma alerts, right? However, if you're out there in the middle of the east side of our district, which we have one of the largest fire districts in the state of Florida, by the way, you can be anywhere, you can be about 40 minutes away to the downtown hospital, correct? So in those circumstances, you may want to consider other options, and this stroke scale helps them determine that. A higher stroke scale may make them call for a helicopter or some other more rapid transport quicker. You also have to consider other circumstances. So pediatric stroke is evolving. I'm not going to even go into pediatric stroke, something that we have to look at. We have to eventually come back and go back to this topic because we're seeing more and more pediatric strokes. Also, obstetrical patients that experience stroke, where are they best served? And how about the hemorrhagic strokes? You need a diagnostic tool for those patients. So there's newer stroke scales now that are coming out, and the key for these stroke scales is they need to be quickly and easily performed. The NIH stroke scale is the gold standard, but it's quite time consuming. How much time does it take to do a NIH stroke scale? You guys do them every day. How much time to do a complete NIH stroke scale? 5 to 10 minutes. That's too much time in the field. And it's too cumbersome, quite frankly, to be accurately performed. But it's really the gold standard test. But pre-hospital exams are now compared to this evolving NIH stroke scale. And the objective of the pre-hospital scan is that it's able to be done quickly and easily and accurately. And it can be compared from medic to medic, and the results are the same all around. It has to have high sensitivity and specificity and sensitivity, or you at least desire it to. Anyone know what the NIH stroke scale sensitivity and specificity is for stroke? Do you think it's high? You think the specificity is high? Does it rule out negatives? Does it rule in positives? We'll find out in a moment. And more double screen stuff here. So what you want to do is choose a scale and train your crew with avoiding changing the scale quickly and frequently. Guys, how many stroke scales have you seen in the last 5 years? Tulio? 3? That's too many changes, right? So you want to find a stroke scale that works for your system, and you want to stick with it and avoid changing it frequently. Please. One of the other things you have to consider is that ELVO is the new STEMI. You guys know what I mean by the term ELVO, right? The emergent large vessel occlusion. That is really where we were in the 70s, 80s with cardiac STEMIs. So if you have a stroke scale that's proper and can identify ELVO, that will allow you to have activate your stroke team in a better manner. And the classic up till now was the race scale. And we'll talk a little more on the next slide about these scales. Should I give it a try?
And I know it's probably just asleep, but man, my arm is numb. And I normally talk so smoothly, but now I'm sounding dumb. But at least I won't need Botox now, cause half my face looks young. This I know, that I've learned. I'm thinking, don't worry about it. I'm thinking it's probably just stress. We both know I ain't got insurance. I could just go bankrupt from one MRI. pathology, at least some kind of scan. And I know each second matters, but each second I lose brain. All the words I lick, I'm spitting now, makes this hard to explain. Cause I know, fish I froze. Wait, what? I'm wishing you'd hurry about it. Lift my arm up and it drips down. We both know I can't talk about it, so it's up to you, girl, to call 911. I can feel my face while does it droop. Cause I'm stroking. Ooh, I can move my arm or I slap you. I can move my arm. Can't you see I'm stroking? Ain't no joking. Ooh, I can feel my face, my tongue won't move. Is it stroking? Am I stroking? Is it stroking? I'm stroking. Oh, I can move my arm and am I screwed? Is it stroking? Is it stroking? Is it stroking? I'm stroking. Facial drip of weakness, speech slurry. Recognize these signs could mean stroke. Though this song is trying to funny, saving brain cells isn't a joke. I can feel my face while does it droop. I can feel my face. Cause I'm stroking. Oh, I'm stroking. Ooh, I can move my arm or I slap you. I can move my arm. Can't you see I'm stroking? Yes, I'm stroking. Ain't no joking. I'm stroking. Ooh, I can feel my face, my tongue won't move. Is he stroking? I'm stroking, girl. Is he stroking? Can't you see I'm stroking? Oh, I can move my arm and am I stroking? Is he stroking? I'm stroking. Is he stroking? 911 right now.
So the FAST exam really identifies patients having stroke, but doesn't really help those patients and those EMTs, paramedics determine whether or not there's a ELVO. In fact, I told you we're going to compare these things. Look at the NIH stroke scale. The sensitivity and the specificity for LVL, large vessel occlusion, with the NIH scale is only 74% and 62%. Identification of stroke, 50-50. That's the gold standard, folks, or what we're using as the gold standard. The race exam, which is adds a couple of things in there, is about the same. Lamb's exam, the same. This is the Cincinnati pre-hospital stroke scale. Kind of dismal numbers. We need something different. So this came out of, this is a study that came out just this year. It came out of Arizona, Dr. Mohammed Talib from Banner Health. And he did this actually remarkable study that looked at stroke, vision, aphasia, and neglect. He called it a VAN exam assessment to determine whether or not a patient had emergent large vessel occlusion and use of it as a screening tool. And the unique thing about this VAN exam is there's no need to calculate a score. The goal was to identify ELVO in patients. And you didn't have to put scores down like the Lamb's exam or other exams, guys. That's pretty nice, right? No worksheets necessarily to figure out whether or not things were going on. The RNs in this hospital in Arizona were trained to perform this study in the ED before the patient had MD evaluation and before they had a CT exam. They had 62 activations of stroke, and 31% of those patients were VAN positive. 31% VAN positive, 39 had an NIH stroke scale of 6. All 14 patients with ELVO were VAN positive. So that's significant. And they were assigned an NIH stroke scale of greater than or equal to 6. And both clinical thresholds had 100% sensitivity. VAN was more specific, 90% versus 74% for NIH stroke scale. And the VAN had 100% negative predictive values. 74% positive predictive value. And the conclusion was VAN accurately identified emergency department patients with ELVO and outperformed the NIH stroke scale by far. In fact, it's probably going to be the study that best allows clinical teams to expedite care and mobilize resources for ELVO patients. And the inter-observer reliability, so they went back and they repeated the studies between nurses and doctors, was 100%. So it's an easy study, it's an easy scale to perform, and the results go from person to person quite accurately. Most annoying. Really what's unique about it is the VAN study takes all the other stroke scales. It uses motor function first, and we'll cover that in a moment. And then it takes all the other, these are the other stroke scales, race exam, the areas of the brain that the race exam looks at. This is the Texas study, 3-limb stroke scale, Lamb's exam, Cincinnati scale. The Lamb's exam takes all of those studies, it integrates the best of all of those other studies, and by doing that, it's able to more accurately figure out whether or not a patient has an ELVL and what their best next course of treatment should be. The other thing it lets you do, and I didn't put the slide in here, is the VAN study also looked at time of activation. And what they found is that the VAN study, although the length of time from the time the patient arrived till getting the blood drawn and so on was slightly increased, they by far exceeded the expectations with the time limit, the time contraction of it, time it took to get the patient to the cath lab, to the biplanar room. You're looking for patients that you can do something about the stroke, pull the clot out, and the VAN study allowed them to really accurately identify those patients. And bottom line is they could cut 50% of the time to get a patient to the cath lab or to the biplane room to get clot removal, which is obviously quite significant. So it's the most accurate tool to date to detect ELVO. It outperforms the NIH stroke scale greater than 6, and it may best allow clinical teams to expedite care and mobilize their resources. So this is the scale. Basically, it starts with weakness. So everyone is assessed for weakness. If they have no weakness, they're VAN negative, and you're done. The exam is done. All right? If they have any weakness, which is mild, moderate, or severe, then you move on. So they have a positive weak sign. And then you look at vision. If there's no changes, you move on. If there's a visual cut, I'm not going to go into details of this, but double vision or new onset blindness, they get a positive scale. Any positive makes them VAN positive, and you're done. So you proceed through aphasia. None, mixed, receptive aphasia, expressive aphasia, very quickly learned and taught and repeated from provider to provider. If there's no changes with aphasia, you move on to neglect, the end part. If there's none, then the patient is VAN negative. But if you find in any of these areas, if you find any positives, that patient's VAN positive, and the possibility of an ELVO is very significant. All right, some other topics in EMS that are really sort of cutting edge, and that is permissive hypertension for ischemic stroke in non-TPA candidates. So it used to be, and this happens in the ER too, by the way, it used to be that I would be contacted 2 or 3 times on patients that had an ischemic stroke, weren't TPA candidates, to try and lower their blood pressure. It's 190 over 100. They can't go to the floor with that, right? Oh yeah, they can. In fact, we all know now that aggressive treatment of those patients can increase their penumbra, can actually invoke a stroke. So we want to, or make the stroke larger. So we want to allow permissive hypertension in non-TPA patients. However, we got to use clinical judgment. So if someone's also having CHF or they have end organ damage, if they're having a dissection, a seizure, other problems like that, their blood pressure may then need to be treated. So you may not have no choice. You may have to go ahead and treat them. For TPA candidates, you want to treat the systolic blood pressure greater than 185 and a diastolic of 110. In the field, this is of great concern. I think it probably is best treated in the ED. At least a MedCom consult needs to happen on the radio. They should be talking with one of the stroke doctors or one of the ER doctors and getting an idea of whether or not they want to treat that blood pressure. there's no definitive evidence that elevated blood pressure increases intracerebral hemorrhage. There seems to be, and there's a thought that that's the case, but there's no conclusive evidence of that. And in fact, in subarachnoid hemorrhage, treatment of elevated blood pressure may actually increase the ischemia of a patient. You want to also avoid meds that can cause sudden and prolonged lowering of the blood pressure. Judicious treatment of hypertension of the patient also has CHF, like we talked about. And really the drug of choice, and one we use mostly in the EDs, is labetalol. There's alternatives, nicardipine, and you pretty much want to stay away from nitroprusside. It's been used previously. They're finding that nitroprusside is known to cause a steal phenomenon, can also increase ischemia, so it's a drug you want to avoid and stay away from. How about glucose control? So in the field, the medics are trained to do a glucose on almost all, you really should be getting a glucose on any altered mental status, and including stroke patients. And they treat those patients now with D10. So if the glucose is less than 60, they can give D10 instead of D50. It's safer. It avoids overshoot that we have to chase and the critical care doctors have to chase in the ICU. And is a smoother way to manage hypoglycemia. Hyperglycemia, not going to do much in the field. However, guys, you need to give a report. You need to make a handoff. You need to tell the ER doc or someone in the ER team, the stroke team, hey, the glucose is 350. That will need to be treated and will get treated fairly rapidly in the emergency department. That's the best site for that. There's some other steps that are considered. What we tell our medics is to avoid excessive fluids. We do the same in the ER, right? We sort of keep them dry. We want them drier than wet unless they absolutely need the fluids. We avoid hyperthermia. And so guys, that's the case in the field. This is the one patient you don't want to wrap up like a taco, like the trauma patient. You want to avoid at all costs hyperthermia in that patient because that also can increase the ischemic changes in the patient. We keep them MPO for obvious reasons because they're going to go into the cath lab, but also these patients get nauseated, start vomiting, and our concern is aspiration. We haven't assessed their swallowing yet. So until we assess their swallowing, we want to keep them NPO. And then what about positioning? We don't concentrate a real lot on this in the departments, but really for an ischemic stroke, you want to maintain the patient supine, but only for a period of time. So in the ED and through the continuum of the ED, patients should be supine, but by the time they're getting into the ICU around 12-hour range, you're going to need to start bringing their head up because you're going to actually increase the ischemic effect. Unless there's subarachnoid or an intracerebral hemorrhage, and if there is in those cases, you want the head up gently. So this is kind of the exciting part for me. I think this is something that I really think would be a reality in our community. What else is new? Have you guys seen any of these drive through our community? Now, I've seen a couple of them come through the community, and it sort of left me puzzled. Like, who's getting a pre-hospital CT scan ambulance? I think it should be MyNCH myself, and I think we should get one now. And although I say this is new, it's not really new. These are out there. And most of the bigger cities, this is from University of Texas Health, this is from Houston, I believe. It sort of looks funny from my perspective. It's a lot bigger ambulance than that. But you can see some unique things here. There's, this isn't normal, guys. What is that? You ever see that in the back, in the side of an ambulance? So it's a cooling unit, a vent to cool the air, helps cool the CT scanner. There we go. And this is inside the rig. You can actually put Dr. Mazen and his crew in there. Our teleneurology stroke folks. This is one of the teleneurologists. And there's the CT scan gantry, and there's a CT scanner. All it is a head scanner. And it's a rapid head scanner. They can slide the patient in. They can do a head CT within 5 minutes, have the patient out. And they're pushing the window on these patients. They're carrying TPA, and they're starting TPA sooner. And now, what kind of time would we save with that? What do you think? A lot of time, probably 60 minutes. I mean, that's a 2 million brain, that's 2 million times 60, that's 120 million brain cells, right? You're going to save tons of time with this. And I don't think it's that far-fetched of an idea. There's a device called the Pulsar. I'm not promoting it. It's a device that you use on a phone, and it's software basically. And what it does is it unifies the continuum of care. It unifies all the persons that are treating a stroke patient, the stroke team, the doctors. It allows them to share EKGs. You can see images, and it also keeps a time clock for you, and it gives you warnings. So if you're delaying your care, it tells you, whoa, you got to step it up, and it reminds you of some of the steps of your care, so that you can more accurately and quickly treat a stroke patient. There's other ideas that are also out there. There's a device called an Alpha Stroke. Anyone hear about it? So this is pretty new in the system. It basically uses electrodes. There's a medical student in Pennsylvania that invented it. It uses electrodes that attach to the skull. It can be used pre-hospital to identify strokes. And what it does is it looks at asymmetry in brain oxygen. It's totally non-invasive. So, you know, you can get the $2 million or $5 million, I think it's around $2 million for the ambulance, or you can get this device for probably around $20,000. It's also non-invasive, which is sweet. I think Dr. will talk about stent retrievers, but the actual removal of the clot has changed, and the devices continue to get better and better every day. And so stent retrievers really, I think, have come into the picture and made big differences on safe removal of clots, and he's going to tell you multiple stories of that. And then I think this is reality. It kind of goes with that CAT scanner. Why do we bring the patient with a stroke to us? Why don't we go to them? Why don't we put a stroke specialist and teleneurologist on the ambulance and go right there to the patient? And I think that's where the future is. Guys, do you guys know how many strokes we took care of last year? Go ahead.
1,200 stroke alerts, 794 were confirmed by CD10.
794. We're not, this is NCH, but this isn't Johnny Gage's NCH, baby. 12, how many? 17? 1,200 stroke alerts in a year. 800 confirmed strokes. So really, you know, we're definitely one of the higher stroke receiving facilities. I talked to the MEC recently about our emergency departments. Our emergency departments see close to 130,000 patients a year, collectively, all of them. That puts us in that puts us like number 26 in the country for volume of ERs. This is no Johnny Gage emergency department. And I think that eventually those stroke teams will go to the patient, deliver their care, start their TPA, and then bring them right to the cath lab and to Dr. Abulwad for his magic that he can do on the biplane room. Then there's this clotbuster ultrasound device. It's kind of an odd-looking device. It sort of looks like wireless headset that you put around the brain. It's used in conjunction with TPA. The objective is it shoots ultrasound in different areas of the brain and helps the TPA work better. It kind of concerns me a little bit. We'll see where that one goes. You know, they've had other devices that they've used, like for DVT in the groin, and those were somewhat failures because of some trauma that occurred when they tried to break up clot in veins. And shooting ultrasound at the areas of the brain where there's a stroke to try and break up the clot. We'll see where that one goes. And there's others which I guess it's really up to our mind to decide what those are. So in review, strokes no longer need to be a terminal event. So grandma no longer needs to get a G-tube and go to a nursing home. And if we do that, we kind of failed. We have to figure out a way to do it better. ELVO is broken out as the Holy Grail. That's the key, guys. We need to figure out who has a large vessel occlusion and then bring them to the right facility so they can get the stroke care that they need. Pick a stroke scale that gets you to the Holy Grail, and it looks like VAN is it. There's data coming out now about pre-hospital use of the VAN exam. We're using it in the hospital. I think it's a great exam. Time will tell as far as if that exam changes much. I think it is really the exam of the future and the stroke scale of the future for EMS. consider permissive hypertension. So grandma can, that's my grandma on the phone with the cowboy hat. This is some years ago. Look at the bell bottoms even then in a grandmother. She was a sweet lady. The most painful thing in my life was taking her key from her. She couldn't raise her hand to lock the door. And I said, Grandma, I'll take the key. And as I locked her door, I locked every memory of my life with my grandmother in that house. She changed forever. And we can do better, and we will do better. Thank you. I'm going to forewarn anyone else coming up here, split screen is challenging over the podium. It's difficult to navigate through your PowerPoint. Anyone with questions for me? Absolutely none? Yes? It's an emergent large vessel occlusion. So that's a patient that has a large vessel in the brain that's clotted. TPA is sort of like, I don't want to use the term, but sort of you know what in the wind. TPA isn't going to change that clot. So they actually have to go in. The objective is to identify those patients with ELVO, and then their procedure is to go in with thrombectomy to actually physically remove the clot, or give TPA directly in that area where the clot is to remove it, as opposed to giving it peripherally. When it circulates through the body, the effect is better. Another question? Thank you.
Do you think that triage and assessment would be effective? I mean, it sounds like a great exam. It's quick. You know, we already do our regular triage, but you know, throw that.
I think a fast exam at triage is all that's needed, and then you know that they're fast positive, and then like Snoop Dogg or whatever his name is, you get that patient from the bar or the triage back to the main area of the ER. Stroke alert's called, and then the stroke alert team does the van exam and progresses through. Anyone else? Yes.
Any plan to purchase portable CT machine in the hospital?
Any plan to push the portable scan? We've been talking about it for 2 years, and I think that's possible. It's a challenge in our community, but I think the heck with the challenges that are there aren't really focused. We're a Mayo facility now, right? We're a Mayo affiliate, and the needs of the patient come first. And we should look at that and say, look, 1,200 patients had stroke, 800 were positive strokes last year, documented known positive strokes. I believe a pre-hospital CT scan would help immensely with decreasing the time, getting our teleneurologist to the patient quicker, and increasing the time decreasing the time they get TPA, and decreasing the time to see Dr. Abulwad and get the clot removed.
No, even for our existing patient, if we can bring a CT machine to them and take them to the CAT scan, they will save us a lot of time.
You mean from the floors?
You mean on the floor?
Yeah. I think that's possible. You're right. What are the things that take time? The things that take time in our department are patients going back and forth. And so the van exam allows us to identify positive van. We do a CT, no contrast in the ER, and then we do a CTA if they're van positive, because we're looking for a large vessel occlusion. And that allows us then to determine who's a candidate to go and get a clot retrieval. But what happens instead is, and I don't think that takes much time, what takes time is bringing the patient back and forth, and I'll be standing there watching, and I'll see the patient go back and forth 2 or 3 times. What's going on? That's all. Each one of those transports takes 5 minutes or so.
It's much longer if it's a vented patient with 8 bombs.
Yeah, absolutely. In the ICUs, I think you'll see it. I believe that there's going to be a scanner of the future that uses a cell phone type of technology. You know, like you see on Star Trek or whatever, where they, yeah, push the window. That's what we have to do it. We have to let grandma survive a stroke now. Anyone else? It's been my pleasure to talk with you guys today. Thank you.